Good morning, everybody. I'm Aaron Miller, Medical Director of the MS Center at Mount Sinai, the Corinne Goldsmith Dickinson Center for Multiple Sclerosis. I want to welcome you all. I'm really glad that so many of you have chosen to spend what looks like a beautiful day here trapped inside with us. We'll try to make it worth your while. I know we're going to have a number of additional people coming in. Hopefully it will not be too disruptive. And I think we're going to have an exciting day. I just want to let you know about some logistics. If any of you want to rid yourselves of your coats and haven't done so, there's a coat check just out in the lobby. The restrooms are on this floor. Ladies' room just outside our doors. The men have to take a little hike down to the end on the right. We have not programmed in any bio breaks into the morning or afternoon, so if you need to use a restroom, please just get up and quietly go out. If anybody needs help during the day, you'll find our yellow T-shirted staff who are currently at the registration desk, but will be around if you need any assistance. There are also some additional restrooms on the conference level, just one flight down. Lunch is planned for 11:30 to 12:30. You're going to pick up boxed lunches outside this room and then come back to the tables for lunch. We are going to have an interesting speaker during lunch, and she'll begin to talk at about 11:55, but we'll remind you of those details later. In your information kits, there's a program for the day, a pad if you want to take notes, and very importantly, an evaluation form that we would really appreciate your filling out before you leave today. You can give it to one of our staff or just leave it on the table and we'll collect it. This will help us a great deal in planning, hopefully, another program for next year. And at this point, it's my pleasure to introduce the first speaker. One of the nice things about working at the Dickinson Center is that we get to train the future generation of physicians who are going to take care of people with MS, and that's one of the absolute joys that I personally experience. Our fellows are a bit like our children, so we take particular pride when they're doing well, and you're going to see one of them do well in a few minutes. Dr. Michelle Fabian joined the Dickinson Center as a fellow in 2009. She completed her neurology training at Mount Sinai, where she was chief resident in neurology from 2008 to 2009, and she did so well that out of all of the hundreds of residents at Mount Sinai, she was named Resident of the Year in that year. Before coming to Mount Sinai, Michelle graduated from the University of Notre Dame and then received her MD degree from Case Western Reserve University. Her fellowship at Mount Sinai is supported by a prestigious fellowship known as the Sylvia Lowry Physician Fellowship given by the National Multiple Sclerosis Society. Dr. Fabian takes part in all of the aspects of clinical care and clinical research at the Dickinson Center. And she's going to start the day off by speaking about multiple sclerosis in 2010, understanding the basics, so that hopefully by the end of her talk, we'll all be on the same page. Michelle?
Thank you, Dr. Miller, for that very kind introduction. I'm really delighted to be here today to give the first talk, which is a basic overview of multiple sclerosis. These are the 5 different areas that we're going to discuss in the next few minutes here. First question is just, what is MS? common presenting symptoms of MS, how is MS diagnosed, classifications of MS, and potential risk factors for multiple sclerosis. So what is MS? MS is likely an autoimmune disease. And an autoimmune disease is a disease where the body's own white blood cells, which are the infection-fighting cells, attack other parts of the body. So it's an inappropriate attack. This may be because the immune cells get confused by other proteins that look similar on bacterial cells and viral cells. So those cells come into the body at some point, and the body has to fight off those infections, and in the meantime gets a little bit confused and starts attacking itself. And then we use the term a lot, inflammation. And inflammation is when the white blood cells go to a certain area to do that attack. And so you'll hear that a lot. This is an area of inflammation. In terms of multiple sclerosis, it is a chronic disease of the central nervous system. And so the central nervous system is the brain, the spinal cord, and then the optic nerves are also attacked in multiple sclerosis. And so for this particular disease, what happens is the body's immune system is attacking what you've probably heard already, the myelin sheath, the covering of the nerve fiber, which kind of insulates the nerve fiber as the message is getting transmitted down from the nerve. And the body's white cells attack that and cause the message to be somewhat disrupted. And you can see that in that second drawing of the nerve fiber there. The first drawing of the nerve fiber is an intact nerve. The second drawing is where there's inflammation. So the body's white blood cells go to that area, cause that attack, and then the message gets a little bit disrupted going through. The nerve itself can also be attacked. You do see that down in the third one. And that's the difference between a white matter lesion. You hear a lot about white matter and gray matter lesions. So the white matter lesion is the lesion where that myelin's getting attacked. It looks white in some of the things we do to look at the brain. And then the gray matter lesion is when the nerves itself are getting attacked. So multiple sclerosis can present in many different ways. And I want to stress that every patient that has multiple sclerosis is a unique case. So we don't make any generalizations. So symptoms can be very intermittent or very constant from MS. Symptoms that occur that are new and they occur over a couple of days are probably caused from inflammation, from that attack of those blood cells on that area. Symptoms that gradually worsen for months or years are likely from that third picture down there of the nerve fiber, from degeneration of the nerve. And so that's a little different. Instead of an attack that's a little bit more immediate, it's a slow injury to that nerve fiber. So what is a lesion? So we use this term a lot in the office, and you hear it, and people say, how many lesions do I have? So a lesion is where those white cells are focused in the brain. And most lesions are silent. So that's an important thing to know, is that for every lesion that causes symptoms, many more don't. So when somebody says, I have X number of lesions in the brain, don't expect that you're going to have the same number of problems coming from those lesions, because most of them don't cause any symptoms at all. The brain does have a little bit of extra space in it. You hear you only use a certain percentage of your brain, and it's kind of true when we talk about lesions. But the problem is, if one lesion is in the right place, it can cause a lot of problems. So if the white cells go to some area that causes a disruption in the message getting through, then a symptom can develop. When a lesion is new, it lights up on the MRI. So that's another term that you may hear from us, is that the lesion lit up. And what that means is when you get the contrast into the, when we give the contrast and it goes to the active area. So that lasts for, weeks to maybe a couple months, but those are new lesions, the ones that light up. And so you see there a picture of a lesion. And then the other slide is just the cells and how they look in the brain. So another question is, what is an attack? Especially when the diagnosis is new, it's very confusing what is an attack. Especially because this is a disease that does involve the brain and the spinal cord, and they really do control every sensation and every function of our body. So it's important to know, because it's very easy to think that a new sensation or symptom is an attack. But the way that we really think about an attack, or you can call it a relapse, or you can call it an exacerbation, it's something that lasts for greater than 24 hours, but it is less than a month. So if you get another new symptom 30 days later, that's a different attack. That's not the same attack. It's usually gradual in onset. So that's why we ask, neurologists love to ask a lot of detailed questions. You've probably noticed that. But if somebody comes in and says, suddenly I had this symptom, we want to make sure that it actually is from the multiple sclerosis and not that it's, a different problem causing those symptoms. It needs to occur usually in a localizable area of the nervous system. So that's why we always are saying, is it the right side, the left side? Is it this or that? Because vague symptoms are surprisingly usually not an attack. Feeling unwell or just generalized issues are not. It usually is something that's focal on the body. Some attacks leave residual symptoms, but 50% maybe is, it's difficult to say if that is true or not. But it is something just to know that it's not that the attack is continuing, it's just that there may be some what we call leftover symptoms. And there's no signs, when we say that it's an attack, there's no signs that it's just your old symptoms coming back or a pseudo-exacerbation. And so that's important too. If you have any new symptoms that last for more than 24 hours, the best thing to do is just to call and let your doctor know. It's always better to discuss with your doctor and for us to tell you, listen, we don't think that this is a new attack. It's better to do that than to sit home and worry that maybe it is. So what are the common symptoms of MS? Again, as I said, every patient is unique. And so if you or your family member has multiple sclerosis, it could be different from what we're discussing here. And the one thing to focus on that I've been taught as a fellow is that MS is an unpredictable disease, but it's not predictably bad. And so that's an important kind of take home. But most common initial symptoms include visual symptoms. So either temporarily losing sight in one eye or double vision, that's very common. Sensory symptoms of numbness or tingling, weakness, or dizziness. Those are very common symptoms. Other symptoms that are important for you and your doctor to discuss are any evidence of previous episodes. So sometimes you do have an attack before you come to the doctor because it's just that you don't, some things are subtle or they're hard to recognize. But looking back, it may be that you had an episode. So that's something to discuss with the doctor. Chronic symptoms, which are going to be discussed later, including those leftover symptoms I had talked about from the previous attacks, any symptoms to do with the bladder, fatigue is a big thing, mood issues, cognitive function issues. These are going to be discussed later in the day. And then any sign of progressive symptoms, where symptoms are gradually worsening. These are all important things that your doctor needs to know that you should discuss. So how do we diagnose multiple sclerosis? As most of you know, it is sometimes a difficult diagnosis to make. And we use this terminology, so I thought it was good to bring this up. way that we diagnose is using a criteria that says that a person with multiple sclerosis has to have evidence of disease that is disseminated in time and in space. And it took me a little while to understand this myself. But evidence of dissemination in time means that you have to have more than one attack. So that's why it's multiple sclerosis. Or you have to have an MRI that shows a change. So if you have one attack, and then on the new MRI that is done some months later, there is evidence that there is a new lesion, then that is pretty consistent with a diagnosis of multiple sclerosis. The other thing you have to have is evidence of dissemination in space. So it has to be that the disease has affected more than one area. And the way that this can happen is if there are, on exam, if there are findings in more than one area, and also on the MRI. The MRI has a characteristic look to it, and there's criteria that we follow to make sure that it looks like that. And then there always has to be no better explanation for the symptoms. So that's our job. Our job is when a patient comes into the MS center, we need to think up all the other ideas of what it could be and then rule them out to make the MS diagnosis. So first of all, of course, we take the history that we had talked about, and then we look at the MRI. So these are just two very characteristic MRIs for multiple sclerosis. The MRI that is on the left, you can see is an MRI where it shows the lesions. The two bright spaces in the middle are called the ventricles. That's what holds the fluid, the cerebral spinal fluid. And then you see these dots around there. It may be a little hard to see, but these oval sort of lesions, these are very characteristic. They line up next to those fluid-filled spaces. And then the other picture is a picture of the MRI. It's, if you can imagine, the brain from the side. And then the dark space in the middle is, again, where the fluid is. And so you see perpendicular to that, these lesions. And those are called Dawson's fingers. You may see that when you're reading about multiple sclerosis. And that's very characteristic, that they line up perpendicular to that fluid-filled space. So we're really looking to see a pattern like this to be pretty sure about a diagnosis. The other thing that is often done is testing a spine MRI. And so this arrow is pointing to a lesion that's in the spine. And so that is very characteristic also for multiple sclerosis. And I want to stress again that we don't necessarily focus as much on what your MRI looks like as what you look like. So patient's always first, but MRI is important to us because it can help us make the diagnosis and help us with treatment decisions. Another test that may occur before a diagnosis is made is a spinal tap. So a spinal tap is not required, especially now that we use MRI so frequently. But in certain situations, it does help us a lot make the diagnosis. And so the main goal of the spinal tap is to look for this thing that is a pretty big word, but the oligoclonal bands. So these are antibodies in the spinal fluid. These are proteins that nobody is really sure why they're there. But when they are there, that's a good sign that this is MS that we're dealing with. So it may help us in a treatment decision, especially in a case where it is pretty clear, but it's not totally clear. When the spinal tap comes back positive, then that's a very good sign that we're dealing with MS. And although there are, nobody wants to get a spinal tap, I'm sure, and there's probably a lot of urban legends about them, it is a relatively safe and minimally invasive procedure. So it's not, maybe the most pleasant, but people really do generally very well with it. We also may check some blood work. And so this is just a list of some things that you may have read about that can mimic multiple sclerosis. So we check sometimes in the right situation for Lyme disease, B12 deficiency, maybe syphilis, and rheumatologic diseases such as lupus or Sjogren's. But very importantly, unless there are other symptoms that point to a different diagnosis, these tests usually don't lead us there. So we really only do the test if we suspect that there's something else going on. So what types of MS are there? Now this is very important, and of course, as a patient, that's one of the most common questions is what type of MS do I have? So we make the diagnosis of MS based on history in terms of what type you have. Okay, so that's just based completely on your history. And that's important to know. It's really listening to you, examining you, and then from there, we can say what type. The other thing that's important to know is that not to get hung up on that. That these are, just because we're looking at you and we're listening to your history, and so we think maybe it's this type or this type, but it is all multiple sclerosis. They're just different subtypes. So the first type that I'm just going to discuss briefly is called radiologically isolated syndrome, or RIS. This is somewhat of a new type of multiple sclerosis. And what happens is patients are getting MRIs for all sorts of reasons now. They're getting MRIs if they, say somebody gets bumped on the head for some reason, falls down, having headaches, they go into the MRI. And then surprisingly, their MRI shows multiple sclerosis, like lesions. So what we do for that situation is we take a history and make sure that there were not any unrecognized attacks. Every case is different regarding treatment, but if a patient doesn't have any symptoms that are consistent with multiple sclerosis, we normally just watch the MRI. If the MRI changes, that may be a different situation, but with a stable MRI, we usually just monitor the patient. The second type of multiple sclerosis is called clinically isolated syndrome. That is when somebody has one attack. And so if somebody comes in with a story that's very good for an MS-like attack, then we look at their MRI. If they have a normal MRI, they have a low chance for another attack. With an abnormal MRI, one like I showed you there, they have a high chance. So we know now, we have a lot of studies that support starting a treatment in most cases in the first episode. So this is always a decision that the patient and the doctor make together, if they're going to start treatment or not. But usually that it is indicated to start treatment. So that's clinically isolated syndrome, one attack. The next type of MS, this is the most common type of MS that patients initially have. This is relapsing remitting MS. This is the history of 2 or more attacks, as I had said, or one attack in an MRI that has changed. So, a key point here is that if you have some leftover symptoms, and I'm going to show you a graph here. If you have some leftover symptoms, but you're stable in between the attacks, then this is relapsing remitting MS. And so these graphs are 2 different patients with relapsing remitting MS. The bar that goes up there is an attack. Okay, so that's disability is the vertical axis there. So when the bar goes up, that's the patient when they had an attack. But then they recover from the attack, and you can see that the line in the middle of the attacks is stable. So that's relapsing remitting multiple sclerosis. And you may see these graphs, when you read about MS. These are very common to see. The second kind of MS that we talk about is secondary progressive MS. This is a history of previous attacks. So you see, again, these are 2 different patients on this graph. History of previous attacks, but then gradual worsening. And then you see in the second patient, the one on the bottom, that there wasn't, even after that patient started worsening, because the line in the middle between the second and the third attack is not flat, but it goes up a little bit, they have some gradual worsening of their symptoms. So they can still have another attack. So you can have attacks, but as long as in between attacks, if there's gradual worsening, that's secondary progressive. So at this point, some patients are on their same medication, choose to continue their multiple sclerosis medication. And then also, it's just really important to focus on symptomatic treatment. So it's very important to discuss with your doctor when you have symptoms, because there are a lot of different things that we can do to make your life more comfortable. This is another kind of MS, primary progressive MS. So you can see in the chart here, there's no attacks. There's none of those vertical bars. But it's a history of gradual worsening of symptoms over time. And then an MRI that's consistent with MS, and potentially a spinal tap. And in primary progressive MS, the male to female ratio is different than in relapsing remitting. And we're going to talk about that later, actually. And then the last type is the rarest type. This is called progressive relapsing multiple sclerosis. And so this is the history of progression and then relapse. So you see here that there's a gradual worsening on that graph, and then one of those vertical bars, that means an attack. And then a little bit more gradual worsening, and then an attack. So this is the least common form of multiple sclerosis. And I know these graphs are a little bit difficult to understand at first look, but if you look at them again, they do make good sense. All right, so we talked about the different forms of MS. So what causes MS? That is the million-dollar question. That's what that is. All right, so currently the cause remains unknown. All right, so the ideas that people have had and are doing research on are, is it caused by a virus, something in the environment, genetics, a deficiency in vitamin D, hormones, smoking. All these things may contribute. These are just ideas and things that people are researching on. So genetics, in terms of risk factors for multiple sclerosis. So in the United States, about 1 in 1,000 people has a diagnosis of multiple sclerosis. And this graph here, which I know it's very hard to read, but what it shows is that there is a genetic component. Now, the bar that's the highest there, that's identical twins. If that bar went to 100%, that would mean this would be all genetic disease. If every identical twin, pair had the same disease, we could say, well, this is clearly genetic, because identical twins share the same genes. But it's not. The risk for a twin is about 25 to 35%. So genetics are important, but they don't have the whole answer. And then when you go to a fraternal twin, the non-identical twin, that risk goes down. And it goes down to the risk for a first-degree relative. And so that's about 2 to 5%. So it's higher than 1 in 1,000, but it's, 2 and 5, between 2 and 5% is still pretty low. And then if you're adopted into a family, you have the risk of the general population. So that just means that it's not all environment either, because you would have the risk perhaps of a brother or a sister in the family. All right, so risk factors in terms of gender. So women have a higher risk for multiple sclerosis than men. And this ratio does seem to be increasing. And I don't think we have a very good explanation for why that is. And also, there is this parent of origin effect, that there's a higher risk of inheritance if the patient is female. So then if, for a female patient with multiple sclerosis, their first-degree relatives have a higher risk than if it's a male patient. And then you may have read about the equatorial risk. So in general, the risk for multiple sclerosis increases with increasing latitude from the equator. And the highest risk is in the white populations of Europe and its former colonies. So Canada, US, Australia, New Zealand. There's a lower risk for African American, Native American, Mexican, Puerto Rican, and Japanese. And it's very rare in Africans, Chinese, and Filipino people. but just because it's very rare, it still exists. But this is in general how that goes. So people have tried to figure out why this is for many years. And maybe one of the reasons or something that can be linked to it is the story about vitamin D. So as many of you may have heard, vitamin D now is being studied in multiple sclerosis, as well as in many other diseases. And so for most people, sunlight is the way that we get our vitamin D into our body, and then diet is a secondary exposure. And if you stand in the sun for 20 minutes and there's a pink glow on your skin, that can mean that you got 10,000 international units of vitamin D. But this is always kind of a risk because we're being told to stay out of the sun because of skin cancer, and also because of MS patients, maybe the heat bothers them. It may be hard to do that. And so many people are deficient. And this is the question: are these deficiencies a cause or are they an association? And the difference there would be, is the vitamin D deficiency, causing the MS, or is it because people don't get in the sun as much when they have multiple sclerosis? We're trying to figure this out. And so there were a couple studies that really kind of keyed people into vitamin D and multiple sclerosis. One was a US military study. So they took recruits and they stored their blood. And this was 7 million recruits, I think. And they stored their blood. And then over the years, they saw who developed multiple sclerosis. And when they found those patients, they tested their blood. And they found that in the white military people, that in the lowest 20% of vitamin D in that category, those people that had the lowest level, they had the highest risk for multiple sclerosis. It went the other way as well. The people that had the highest vitamin D had the lowest risk for multiple sclerosis. It didn't hold up for the minorities in the study, but this was a small number of people. It was about, in the 200, I think 250 some people. So this is a small number. And then there was another study, the nurses study. This was over the course of many years, and it was many thousand nurses. And they found that those who took vitamin D supplements showed a trend towards a lower risk for multiple sclerosis. This is hard because they were checking in every couple years to see what they were taking in terms of their supplements, and it's hard to know for sure if it was something else those nurses were doing that decreased their risk or if it was the vitamin D. But it's very interesting. But the way that we can maybe figure this out is we need a trial in vitamin D supplementation to see if this really is something that can help us in multiple sclerosis, either decrease the risk for getting it or in terms of treatment to help make it less severe. Another thing, a risk factor that we now know is smoking. So who in this audience knows that smoking is bad for multiple sclerosis? Okay, we're kind of doing our job here. All right. Smoking is bad for multiple sclerosis, all right? And so this is something in the past few years that we know. We also, it's something that's suggested. It's an association. And we also know that smokers have potentially a higher risk for quicker progression. And so really, patients with multiple sclerosis should stop smoking. And primary care doctors can really help out with that. So that's something to talk to your primary care doctor about. In terms of pregnancy and multiple sclerosis, the risk during pregnancy is lower for an attack in the 3rd trimester, and it's higher in the first 3 months after the pregnancy. And we've seen this in some multiple studies now. So this is just something to discuss with your doctor. We always say we love babies in the Multiple Sclerosis Center, and pregnancy is definitely something that's possible, and patients do very well. And breastfeeding is something that's unclear if it's right now protective or not, and so that's really a decision of the mother, and then, again, discussion with doctor. In terms of a diet, we don't advise any special diet. There's no evidence that any restriction or supplementation is protective or helps the multiple sclerosis. And so we want you to eat healthy. We're doctors, so we want you to eat healthy, but nothing special. And stress. So many people say that stress can increase their symptoms or potentially cause an exacerbation. We don't have conclusive evidence for this, but we still want you to minimize your stress because everybody feels worse when they're very stressed out. And just in terms of heat, some MS patients have worsening of their symptoms in the heat. So it's not dangerous, although it is uncomfortable at times. So if it's bothersome to you, drink cool water and try to keep your body temperature down. So in summary, MS is a disease that has variable symptoms. The things that we know are that stopping smoking and vitamin D supplementation are potentially something that can modify the disease. And we make the diagnosis by history and MRI, and the classifications of MS are based on history. And the goal of the healthcare team is to allow for the healthiest and most comfortable life possible for every MS patient. Thank you. I now have the honor to present our next speaker, Dr. Aaron Miller. Dr. Miller is professor of neurology at Mount Sinai School of Medicine and medical director of the Corrine Goldsmith Dickinson Center for Multiple Sclerosis. He has served as a chairman of the clinical advisory board of the National Multiple Sclerosis Society and has been chief medical officer of the National Multiple Sclerosis Society since 2001. In addition, he was elected to the American Academy of Neurology Board of Directors in 2009. And to me, he has been an incredible mentor in this field. Please welcome Dr. Aaron Miller.
Thanks, Michelle. I'm sure you all agree that Dr. Fabian gave an outstanding overview of the state of MS today. You'll have a chance to ask some questions to her as well as to the other morning speakers right before lunch when we have a panel to answer questions. I'd just like to ask for a show of hands of how many in the room have actually heard about CCSVI or chronic cerebrospinal venous insufficiency. It seems like a lot more of you than know that smoking is bad for MS. So I think that shows the power of the internet. My job this morning is to address this extremely provocative and controversial subject. The idea of therapeutic claims in multiple sclerosis is nothing new. For many years earlier in my career, there was a book published every few years called Therapeutic Claims in Multiple Sclerosis. And it included literally dozens of things that have been tried, and not only tried, but touted as treatments or cures for MS, none of which stood the test of time. Once we began to get some pharmacological treatments for MS, that book seemed to have withered on the vine. But despite that, there have been no shortage of therapeutic claims in multiple sclerosis. And before I talk a bit about CCSVI, I want to just talk about a few of those that have occurred. The former chairman of neurology at Columbia University, who was regarded for years as the dean of neurology in the United States, once said, "I know of no better way to ruin a good career in neurology than to advocate a treatment for multiple sclerosis." So that statement partly accounts for the caution that I've displayed over the years in talking to people about various therapeutic claims. So far, I hope my reputation has remained relatively intact. Well, here are a few of the MS miracles that have cropped up over the last 2 decades. Hyperbaric oxygen, dental amalgams, or removal thereof, and a substance called prokaren. Now, the reason I want to bring up the subject of hyperbaric oxygen, which are these chambers with high-pressure oxygen, they're very good if you're a scuba diver and get the bends. It's good to go into one of those chambers, and they might help with wound healing. But back in 1983, in perhaps the most prestigious journal of medicine that we use, the New England Journal of Medicine, there was a report of the advantages of hyperbaric oxygen as the treatment of multiple sclerosis. And this, in fact, was a randomized placebo-controlled double-blind study, or so it purported to be, and we'll talk about some of those words later. But alas, it turned out that as people continued to try to use hyperbaric oxygen, that it turned out to be absolutely worthless for the treatment of multiple sclerosis. In December 1990, one of the most watched versions ever of CBS's 60 Minutes program involved an interview by Michael Saylor with Dr. Hal Huggins, a dentist who claims that removal of dental amalgams, the fillings in your mouth, would cure multiple sclerosis. And in fact, he was happy to provide that for $8,500 a treatment, which in $1990 was a substantial amount of money. Now we know that the removal of the dental amalgams are perfectly safe. Numerous studies have shown that, and removal does absolutely nothing for multiple sclerosis. Hal Huggins had his license to practice dentistry revoked in 1996 after a panel found him guilty of gross negligence. And Time magazine reported the judge's conclusion that Huggins diagnosed mercury toxicity in all his patients, including some who didn't even have amalgam fillings. This is pretty distressing, but even to this day, I occasionally see a patient who tells me that they have recently gone to have their dental amalgams removed. And a few days ago, I went on the internet and Googled Dr. Huggins and found that despite the fact that his license has been revoked, he continues to have a site touting the benefits of mercury amalgam removal and selling a variety of other items on his website, including this book. Another putative cure or treatment for MS is a substance called prokaren. A nurse by the name of Elaine Delac was diagnosed with multiple sclerosis in 1988. In 1999, she began to sell prokaren, which formerly was spelled with a C rather than a K until Pfizer Pharmaceuticals protested its similarity to one of their drugs, and she had to change the name. But she claimed that when she took prokaren, it fully controlled her neurological symptoms. Now, what is prokaren? Prokaren is a transdermal gel. That's something you smear on your skin. It gets absorbed. It contains two simple ingredients, histamine and caffeine. This costs about 30 cents probably to make. She sold it for about $250 a month. There's absolutely no evidence or biological plausibility of value for prokaren. Yet if you go on the web, and this is a little bit hard to see, it's not a really well-designed website, but you can still see that she's touting prokaren for multiple sclerosis. She seems to have moved into the cosmetic area. She now has prokeratin, which I guess will get rid of your wrinkles as well. So there's nothing new about seeing things touted for multiple sclerosis. And what this emphasizes, I think, is the importance of critical thinking and information from professionals about these claims. Which brings us to CCSVI, or chronic cerebrospinal venous insufficiency. So is this going to turn out to be an effective, something that truly is related to MS and potentially an important source for treatment, or is it going to turn out to be medical malarkey? And the upfront answer that I would give at this point is we don't know for sure yet. Where did this idea come from? Well, it came from an Italian vascular surgeon by the name of Paolo Zamboni, who reported in early 2009 that based entirely on the use of a non-invasive diagnostic procedure involving ultrasound. So that means you put a probe on the neck, basically, and you get you can create an image based on the use of ultrasound. And he studied 65 MS patients and 235 controls. And he labeled 5 factors that he considered to be indicative of abnormalities in the veins that drain the brain and the spinal cord. One was the reflux of blood into the internal jugular veins or the vertebral veins, which are veins that drain the back of the brain. Or you could have reflux into those are basically neck veins. Or he said you could have reflux of blood back into the veins that are in the brain itself or in the deep venous sinuses. Or he could detect stenoses, meaning narrowing in the internal jugular veins. Or he could have failed to obtain an ultrasound signal from the internal jugular veins and or the vertebral veins. And finally, that the cross-sectional area of the internal jugular vein was greater in a sitting position than when the patient was lying down. Now, he defined CCSVI as the presence of at least 2 of these 5 parameters. But one thing I want to emphasize that you must understand is that at this moment, CCSVI is not a disease. It's a condition described based purely on these ultrasound observations. It remains to be determined whether those abnormalities, if they indeed exist, are related to a disease, specifically the disease MS. Now, one of the astonishing things about Zamboni's report was that he indicated that in his hands, 100% of MS patients and none of the controls had any of these abnormalities of the veins. And he proposed that impaired venous drainage of the brain or spinal cord, which he felt resulted from these abnormalities, led to a breakdown of what we refer to as the blood-brain barrier. Ordinarily, there is a biological barrier between the blood and the brain that keeps bad things out. And he felt that these venous abnormalities led to disruption of the blood-brain barrier, which resulted in accumulation of iron in the brain, and that in turn caused MS. There is indeed an increased amount of iron in the brains of MS patients, but there is also an increased amount of iron in the brains of people with a large variety of other degenerative neurological diseases. It's not at all specific to MS. Well, a number of months after the publication of Zamboni's report, the Toronto Globe and Mail, which is the equivalent in Canada to the New York Times, picked up this story along with their television subsidiaries and a lot of internet publicity, and they ran with this story indicating that CCSVI was a likely cause of MS, and that by fixing these abnormalities, one could get rid of MS. Naturally, and not surprisingly, that story gained a lot of traction. We would love for something to be as easy to fix a serious disease as opening up the veins. But soon after, many scientists provided a number of critiques of Zamboni's initial study. First of all, the data was based entirely on ultrasound technology. Ultrasound is very operator dependent. Just simplistically thinking, for example, how hard you press on the neck influences what your observations are likely to be. The technicians were unblinded, which means that they knew which patients had MS and which patients did not have MS, and that leads to the possibility, since they're trying to find something, of bias in the study. The normal venous anatomy in humans is not well defined, and even more importantly, the venous drainage of the brain is highly flexible and redundant. That is to say that very few people are alike to one another in terms of how they drain blood from the brain, and the blood almost always finds a way to get out. So if one vein is blocked, there are lots of other ways for the blood to get out, and blood doesn't really back up into the brain. And in fact, for years, surgeons, for a variety of reasons, have been tying off the internal jugular veins. This particularly happens in people who have head and neck cancer and need major procedures to get rid of that cancer. And the surgeons often need to tie off these internal jugular veins, and absolutely nothing bad happens to these patients as a result of that tying off. Interestingly, there have been no previous descriptions of so-called chronic cerebrospinal venous insufficiency. There is no previous evidence of venous insufficiency in the brain. Again, to emphasize, it's an operational definition that Zamboni provided. There are people who naturally have blockage of their internal jugular veins, and they've never been previously noted to have multiple sclerosis. And when you do block veins in such a way, and that does happen in certain other disease states, if you have very marked and significant blockage in the veins, you get certain symptoms. You don't get MS, as far as we've known up till now, but you do have signs like redness of your eyes and plethora of your face gets red. And one doesn't see any of that in the patients with so-called CCSVI. Zamboni claimed that the ultrasound technology provided 100% specificity. That meant if you had it, you had MS. 100% sensitivity, meaning he found it in every patient. It had 100% predictive value, positive predictive value, and 100% negative predictive value. That equals 100% incredible. That is something that never happens in biology. Nothing virtually in biology is an all or none phenomenon. So whenever you see data like that, it immediately should make you raise an eyebrow and say, maybe something is fishy here. In other words, if something sounds too good to be true, it probably is. Well, after Zamboni's original paper describing the finding of these venous abnormalities in people with MS, he published another small study in which he treated patients with MS in whom he found these abnormalities. And he called that procedure to open the veins the liberation procedure. This was a pilot, non-randomized study, means he picked the patients specifically, done all in one center, and he dilated the veins with balloon angioplasty. Angioplasty is, you put in a balloon, you blow it up, and you open the veins. He had no control group. In order to do a proper therapeutic trial and avoid bias, one always wants to have a control group, and you want to blind that. That is, you don't want the people who are judging whether the procedure has worked to know who's actually gotten the real procedure and who's gotten a pretend procedure. Zamboni himself noted in his study that he didn't see any benefit really in patients with progressive or advanced MS. He said he only saw benefit in reducing the frequency of attacks and MRI changes. That kind of observation in open studies where you don't have control groups is seen in virtually every MS study. Relapses, patients who are chosen because they have a lot of relapses, if they go into studies, they tend to subsequently have fewer relapses. And importantly, in Zamboni's hands, 47% of the patients who had their jugular veins opened had experienced re-narrowing of them in a very short time. Well, after the publication of the surgical results, the so-called liberation procedure, there came an internet frenzy. Over 140 blogs have cropped up to tout the advantages of the liberation procedure, testimonials from people that have had them. This is one, a popular blogger called the Wheelchair Kamikaze, who's here in New York. He actually went to Brooklyn and had his procedure done. He didn't really have much of a particular benefit. And that site in Brooklyn was subsequently stopped from doing these procedures until they were able to achieve approval from their institutional review board. particularly in Canada, there has been a great deal of anger about the inability of Canadians to obtain these procedures. Canada's healthcare system, as you know, is very different from that in the United States. And in Canada, doctors have to recommend you for the procedure, and the individual provincial governments have to have decided to pay for that procedure. Otherwise, you simply can't get the procedure done. In this country, we work differently, and if you are able to find a surgeon or an interventional radiologist who's willing to do the procedure, and you can pay for it in one way or another, you can have it done. But this has led to a huge amount of outrage and protest, particularly among the Canadian population. This is just one sort of tongue-in-cheek image that I found on the web about how to influence the government to fund treatment for CCSVI. Companies have sprung up which will enable you to go to various parts of the world. This is a phenomenon known as medical tourism, or in this instance, surgical tourism. And this company will arrange for you to go, in this case, to a couple of sites in India. But if you Google this subject, you'll also find sites in Romania, Kuwait, Costa Rica, Poland, a lot of places where the nature of the care that one is going to receive really may be suspect. One thing I want to point out about all of these images from the web that I've shown you is the dangers of surfing the internet. There's a lot of very valuable information on the internet, and specifically about MS, there's a lot of very valuable information, but the information that you see on the web is unfiltered. And so if you don't know the validity or reliability of the site, you can really be fooled by some very attractive sites. I want to point out to you, I can't really point here because I can't see the screens well, but 4 boxes, tabs from the right, is something called testimonials. As a general rule, if you come to a website that has testimonials, I would say be wary. But these companies will arrange your flights, your hotels, in some cases additional sightseeing, along with your surgical procedures. Well, soon after the results of Zamboni's surgical procedures were announced, other sites began doing this, and sadly, a few very serious and other potentially serious complications have occurred. A prominent interventional radiologist at Stanford University in California did these procedures, and one patient experienced a fatal brain hemorrhage. And another patient in whom a stent was employed. Stents are the wire mesh structures that are used to hold open vessels. You all know about their use in coronary artery disease. The problem is that stents are designed for the fairly rigid structures of arteries. They aren't designed for the much more pliable veins that are involved here, and there are no stents that are specifically designed for veins. So using these arterial stents in the veins carries additional dangers, and in one case, the stent migrated out of the internal jugular vein into the heart and required open heart surgery. In addition, when the veins thrombose, patients have to go on blood thinners. And whenever you're on a blood thinner, you're at increased risk for potentially serious bleeding. So it's not really something to undertake lightly to be on a blood thinner. Well, every once in a while then, a crazy idea is just a crazy idea. But sometimes it's not. These little squiggly things on the left are an image of Helicobacter pylori. And Helicobacter pylori is a bacterium that now we know causes peptic ulcer disease. When I was a medical student and a resident, we were taught that it was going to be people like me, type A personalities, who were going to end up getting peptic ulcer disease because of stress and stuff. Now we know that that's got nothing to do with it. Basically, it's caused by a bacterium. Nobody would have thought that 40 years ago. So we were at a crossroads in the scientific community, what to do about CCSVI. Although most scientists didn't believe it was really likely to be true, and even if it is true, it may just be an association. It may have nothing to do with causing MS, and fixing it might have no benefit. It just might be an association. It could be caused by MS rather than be the cause of MS. So I would say the community was polarized about what to do about this, but as Yogi Berra says, if you come to a fork in the road, take it. So the National MS Societies of Canada and the United States chose to take the fork that led to further study of CCSVI. But they realized that studies of CCSVI had to be done upholding some important scientific research principles. And one of the principles of science is that if results are true, they will be able to be replicated in other laboratories. So the society said the first thing we have to do is, if Zamboni's data is correct, other labs, other investigators ought to be able to find the same thing. Secondly, you need to use proper control groups. So you can't just study MS patients, and in a blinded way, you have to look at normal people and people with other neurological diseases. And the funding should be subject to peer review. That is, other experts should look at the proposals and decide which ones have merit and which have less merit. And finally, specifically looking at therapeutic investigations, but even in some cases at diagnostic investigations, we have to make absolutely sure that we preserve the safety of the subjects that go into those studies. So the two societies put out what's known as a request for proposals for any proposals from around the world to come in and be reviewed. And they gathered an international panel of experts from multiple disciplines. So that panel included neurologists with an interest in MS. It included imagers, MRI specialists with an interest in MS. It included interventional radiologists, the people that would clean out your veins if this turned out to be useful. It included vascular surgeons, and it included statisticians. And they reviewed what I think were 29 proposals that came in, and they decided to fund 7 of those studies here in North America, providing $2.4 million to look at those. And they set out, in selecting these studies, they were chosen for specific reasons. Number one, it was felt absolutely critical that some of these studies needed to use exactly the Zamboni techniques to be able to reproduce, or not reproduce, Zamboni's ultrasound studies. But in addition, if the ultrasound observations are valid, then one ought to be able to demonstrate the venous abnormalities by other techniques which may in fact be more reliable. So some of these studies look at other methods of measuring flow in the veins or pressure if that's built up if the veins are blocked. And it was felt important to study a variety of populations, most importantly, those with early disease, because if CCSVI exists and is a cause of MS, then it should be present in early populations. So some of these studies include patients with clinically isolated syndromes. Dr. Fabian told you these are people who have had the first episode of something that's likely to turn out to be MS. And it also includes, in one or two of these studies, a pediatric population. MS is relatively rare in children, but it definitely occurs, and these are the earliest people. So I'm going to just very quickly give you some of the highlights of what some of these studies that were selected are going to be. Brenda Banwell, who is a pediatric neurologist specializing in MS in Toronto, is going to be focused particularly on children and teenagers, and she's going to look at magnetic resonance venography. You'll see this in some other slides as MRV, This is another method more reliable than ultrasound for imaging the veins, but in a non-invasive manner. We use the term non-invasive, meaning it's basically not carrying risk to the patients. This is done by MRI techniques. And she's also going to look at blood flows. Another Canadian, Fiona Costello in Calgary, is going to look at a variety of controls as well as MS patients and try to link these vein abnormalities to the question of disease activity and tissue damage. Aaron Field in Wisconsin is going to add another newly developed technique called quantitative time-resolved 3D MR venography, which may be an improvement in the technique, as well as looking at ultrasound in both early and later MS and controls. Bob Fox at the Mellon Center in Cleveland, a colleague of our guest speaker, Dr. Cohen, is also going to take a look at very early disease, and they add the unique ability to examine the venous system in autopsy specimens. They have a setup for looking very early or collecting very early after death the brains of some people who had MS and died to get additional information. Dr. Torres in Ottawa is going to look at the high field strength MRI focusing on the iron question in MS. Tony Trabulsi in Vancouver is going to add studies on twins, including the monozygotic twins, meaning identical twins. And in addition, he's going to use an invasive technique in which catheters are placed. This is the most definitive way of demonstrating narrowing of the veins in some patients. And finally, Jerry Walensky in Houston is going to sequentially use a series of techniques, starting with those patients who show abnormalities on ultrasound, to see if then that can be confirmed with other kinds of measures. So I would say that after the conclusion of these 7 studies, which will be about 1 to 1.5 years from now, we should really know much, much better whether Zamboni's work is a valid observation and whether we should go on with therapeutic studies. Now, there have been some subsequent studies already. Robert Zavadanoff in Buffalo and his colleagues, who have been proponents of the CCSVI idea, did already a large cohort of patients, and you'll notice that already the Zamboni numbers are dropping dramatically. So Zavadanoff's initial report found roughly 60%, not 100% of MS patients had this, but interestingly, about 25% of normal people had these so-called vein abnormalities, and about 45% of people with other neurologic disease had the abnormalities. There have been several other European studies noted on the screen, very small studies, all of which have been negative, have failed to reproduce Zamboni. And there was just last week a very large MS meeting in Europe in which several additional studies still failed to replicate Zamboni's work. Perhaps most interesting among them was a paper by Baroncini, another Italian group, and they found no evidence of CCSVI in patients with clinically isolated syndromes, suggesting that it may not be a cause. And Dr. Zavadanoff himself is now backing off from the idea that CCSVI may be a cause of MS. He's now saying that he believes still that there is the presence of these vein abnormalities, but that it's more likely to be a result than the cause of MS. I should note that one of the Polish groups, Simka and colleagues, did report their results in terms of safety on a number of these procedures that they did, and they did not report in their hands any life-threatening complications and few major complications among several hundred patients that they had done. Well, I attended a meeting in Ottawa in August convened by the equivalent of the National Institutes of Health in Canada to address the question about funding therapeutic trials in MS. And the head of the institute asked the question, should they fund trials? And I came back to him and I said, to me, that's a little bit like asking the question of whether or not we should fund a study to rid the world of flying saucers. First, we need to find out if there are flying saucers. What we know at the present time is that there are some people who believe there are flying saucers. And there are a lot of people who believe that there are vein abnormalities in MS, but we haven't proved that, as I think I've indicated to you. We need to first clearly establish that there is an abnormality of CCSVI. If there is indeed an abnormality, if there is a real association, then by all means it's reasonable and almost mandated that we go ahead and do a properly designed therapeutic trial, but not before we confirm the observations. To do otherwise is putting the cart before the horse. This was the conclusion of the Ottawa meeting in August. The head of the institute wrote a day or two later, in the absence of clear and convincing evidence for CCSVI, the performance of an interventional venoplasty trial with its attendant risk to MS patients is not appropriate at this time. It is unlikely that a proposal would pass a peer review panel because evidence that CCSVI exists is currently lacking. Similarly, there are serious ethical issues associated with doing such a trial given the lack of convincing evidence for CCSVI. That, however, did not end the controversy in Canada. And just 4 days ago, the provincial government of Saskatchewan announced that they are going to allocate $5 million to do a clinical trial of the so-called liberation procedure in Saskatchewan. And Canada is very interesting because a lot of these, the provincial governments control a lot of these operations or procedures. So as I reflect on the situation of CCSVI and how we've gotten where we are today, I think we've had the creation of the perfect storm for a medical controversy. We have a population with a serious or at least potentially serious illness, and it's highly understandable that people in this situation would welcome, as we as professionals would welcome, a quick and easy fix to this illness. And you compare the attraction of a one-time, relatively straightforward surgical procedure to the long-term use of unpleasant and sometimes ineffective drugs, and the attraction is obvious. There was a scientific presentation in a respected peer-reviewed journal, followed by the therapy journal. That's important, but as I showed you with the New England Journal report of hyperbaric oxygen, that's not enough to guarantee that it's valid. It needs to be replicated. Unfortunately, Professor Zamboni chose to label his surgical procedure with the politically charged provocative terminology, liberation procedure. And then, like Rodney Dangerfield said, take my wife. Professor Zamboni's own wife has MS, and he did the procedure, or had the procedure done on his wife. Finally, we have the phenomena of the modern media and the social media. So the continued promulgation of this story by the mainstream media through print, TV, and the internet has fanned the fires. And the impact of social media has been absolutely extraordinary. If we were delivering news by Pony Express today, I don't think the controversy about CCSVI would have reached this proportion. But when within seconds or minutes you can distribute information to millions of people, and anybody can say anything and reach anybody, the situation has dramatically changed. And then we had, unfortunately, the initial response of the MS societies in the US and Canada. I don't think we're sufficiently sensitive enough to recognize the importance of this issue for people with MS. So finally, I'm going to conclude with my own personal conclusions about where we stand with CCSVI today. So the intense interest of people with MS in CCSVI and its potential treatment is completely understandable. I believe that patients have the right to make their own decisions about their care, and those decisions deserve our respect as professionals. By the same token, however, we don't have an obligation as professionals to refer people for procedures that we feel are unwise in our professional judgment or are premature. Remember again that CCSVI is currently a term that's defined exclusively by ultrasound technology, and it hasn't been established as a disease. The biological basis for the condition is very weak, and past clinical experience casts doubt on its existence. Mounting evidence suggests that the Zamboni observations may not be valid, but in my view, the completed studies to date are insufficient to completely refute the observations, so that ongoing, properly scientifically designed and controlled investigations, which are now funded and have been initiated, I think should answer the question about the existence of CCSVI in MS. And finally, unless and until the validity of the association of CCSVI and MS is confirmed, I think that clinical trials of therapeutic interventions are premature, they subject patients to risk, and they potentially waste valuable research dollars. Thank you for your attention.